Good evening. My name is Dr. David Doman, and welcome to another edition of Housecall. What's new with hearing loss? Find out more right now. My guest this evening is Dr. Mostafa Ahmed, an ear, nose, and throat physician who has an interest in hearing loss. Mostafa, welcome to Housecall.
Thank you. Thank you, Dr. Doman. Appreciate the interview.
So briefly tell our viewers about your professional background.
Certainly. So I grew up in northern Wisconsin and went to college at Washington University in St. Louis, joined the military, and through the military had a fantastic exposure to ear, nose, and throat surgery training in San Antonio, Texas. I spent several years in Texas at Fort Hood as one of the primary ear surgeons for approximately 250,000 soldiers and their family members. After that, I then relocated with my family to Washington, D.C. area and completed my final year in the military at Walter Reed National Naval Medical Center. And since then, I've stayed very interested and active in the advances in hearing loss surgery, as well as research, and hope to share today some of the new advances, particularly with cochlear implants.
Dr. Ahmed, give our viewers a sense of how common is hearing loss in the USA.
Hearing loss is the most common disability in the United States. Many times, patients go undiagnosed with hearing loss for decades. It has a rather insidious presentation. People may not realize that they have hearing loss, but throughout the next few minutes, I hope to be able to share some of those signs and symptoms of hearing loss.
So for a USA population of 340 million people, give us, the viewers, a sense of how many millions of people have hearing loss. Just a broad brush projection.
Anywhere between 30 and 50 million people are walking around right now with some degree of moderate to severe hearing loss. And we anticipate that number to go up as the population ages. Additionally, there are patients that are younger as we start having more auditory input through headphones, AirPods that can damage hearing. So we definitely have to work on protecting the hearing of our younger population as well.
Now, of course, hearing loss can lead to social limitations, but I also understand it can lead to economic limitations, and there's also concerns about long-term leading to memory loss and even dementia. So can you amplify for our viewers all these potential consequences?
Certainly. Well, we'll start off with younger patients. So younger patients that are born with hearing loss, the patients that have congenital hearing loss, they have, if it's untreated, of course, they have less economic output and productivity compared to their hearing peers. Their IQ scores tend to lag behind. Additionally, their school performance will also lag behind. The flip side is if you treat hearing loss and identify it in young children, they match all of their hearing peers without any gap. As we start looking at older patients, we have a lot of issues in terms of socialization, the increase of depression and anxiety. You can also have issues in terms of marital issues as spouses are unable to communicate through progression of their hearing loss. So it can be really a vast impact on that person's social, economic, physical, mental well-being. The data about dementia has really started to crystallize in the last 5 to 10 years. Many of these studies have been population-based, and we're starting to see data that shows that the brain actually begins to shrink in patients with hearing loss. There are a recent study with about 150,000 people looked at the correlation between hearing loss and the presence of a tau protein, which is seen in the development of Alzheimer's disease, a form of dementia. And it is a very strong association now that is becoming more and more important for a lot of the patients that I see. So definitely something that we need to be aware of as we move forward.
What are the many causes of hearing loss? Young individuals and, of course, older individuals.
Yes. So in younger patients, we tend to look at hearing loss as a form of some sort of congenital or genetic disease. The most common genetic disease is, in fact, connection 26 mutation. It's actually fairly common. 1 in 1,000 people carry the mutation. And this can sometimes lead to progressive hearing loss throughout the patient's life. That's more of what we call the sensory neural component. As you start to age, the other types tend to be more in the conductive hearing loss. Trauma to the ear can cause damage to the hearing bones, the eardrum. And as you then start to age further past the age of 50, almost all patients have some degree of sensory neural hearing loss. And this can really be missed through several decades until the onset of dementia and social consequences of hearing loss are seen.
So if somebody comes to see you and they're complaining of hearing loss, what kind of diagnostic evaluation do you initiate?
Right. So the first step in any consultation that I'll have with the patient is to get a very thorough history. I want to know their family history of hearing loss. Did any of their parents, grandparents wear hearing aids? Do their children have hearing aids? Are they exposed to different medications that potentially could damage the cochlea or the hearing apparatus? We want to know what their occupation is and really capture a risk profile for this person's hearing loss type and risk of progression. The second thing is a thorough exam of the ear, nose, and throat. Sometimes patients can have sinus problems that can cause hearing problems, and we want to identify those. Sometimes it can be a problem within the middle ear. So really looking at the ear with a high-powered microscope is really something that can be very useful diagnostically. And then the final step is going to be getting a comprehensive audiologic evaluation or an audiogram. Our audiologist will go ahead and assess various functions of the ear. We'll test to see the sensitivity to sounds. We'll see how well patients can discriminate different words that sound similar. And lastly, we'll test to see how the middle ear is functioning. The results of this audiogram will then inform me to decide if I need to go ahead and get a CT scan of the temporal bone of the ear or an MRI of the internal auditory canal, because there are some rare but serious processes that can be identified as long as we choose the correct imaging modality.
So this evaluation will, number one, rule in or rule out hearing loss. And if it's present, will it also tell you the degree of hearing loss?
Certainly will. And that's one of the key components of this. We rank hearing loss and categorize it into normal, mild, moderate, severe, and profound hearing loss. Those degrees of hearing loss all have an impact on that patient's ability to communicate, have meaningful conversations with others, as well as can have serious consequences in terms of their cognitive performance. So if a patient also presents to us with usually mild to moderate hearing loss, we'll usually recommend some sort of a hearing aid if there's no involvement of the tympanic membrane or the eardrum or the hearing bones. Once we start getting into the severe to profound range of hearing loss, that's when I have conversations with patients and their families about cochlear implant to somewhat bypass some of the damaged structures in the ear.
You mentioned some terms that you and I understand, but I think we should define and amplify it further for our viewers. Discuss sensory neural hearing loss versus conductive hearing loss. We are showing up on the screen the anatomy for our viewers to follow along, but please explain the differences and the anatomy.
Absolutely. So one of the key components of how we classify hearing loss is conductive and sensory neural. So the process of hearing happens at the very beginning of the ear. So where we look at the cartilage where we place our headphones, the air travels through the ear canal, reaches the eardrum, the tympanic membrane, and then vibrates 3 tiny hearing bones. That any pathology or problem with that sound wave traveling to those hearing bones causes what we call conductive hearing loss. Conductive hearing loss many times can be corrected with some sort of procedure or surgery. Then when we talk about sensory neural hearing loss, the sensory part of sensory neural is a damaged cochlea, where the ability to convert sound to electrical or nerve impulses that send to the brain is damaged. So the cochlea is, you can think of it as a converter of sound energy to electrical energy. Then when you have the neural component, the sensory neural, that's where you have the hearing nerve that travels through the temporal bone and into the brain. Any masses or tumors that affect that nerve will cause a sensory neural type of hearing loss.
Dr. Ahmed, we're going to pause briefly for a public service announcement. More with my guest, and we're discussing hearing loss. We'll be right back.
Okay, Dad, look at you.
I look nice, don't I?
I see you.
Yeah.
Adding your own flavor to fashion comes with age.
Oh, man, that's the best one yet.
Forgetting how to add doesn't. Finding it difficult to work with numbers may be a sign of Alzheimer's.
Dad, are you okay?
An early diagnosis can help improve the quality of life for your loved one.
All right.
High school. Yeah.
Hey, Dad. Do you want to talk about what happened earlier?
Learn the warning signs of Alzheimer's. Some things come with age. Some others don't.
We're back. We're discussing hearing loss in this evening's program. When we paused for the public service announcement, we were discussing sensory neural and conductive hearing loss. Let's go on now to discuss some of the treatment options available. Mostafa, when do we use hearing aids to treat hearing loss?
Right. Yeah. So hearing aids are the workhorse for the treatment of the two main types of hearing loss: conductive hearing loss and the nerve or cochlear related hearing loss. They are usually effective for patients that have mild to moderate and even severe hearing loss. And the idea here is to amplify or to provide a stronger sound signal so that the cochlea can make a electrical signal conversion into the nerve. It's a way to bypass the potentially the damaged eardrum, hearing bones, and even some of the damaged cochlea. Many times, though, patients will find that the sound of a hearing aid is not necessarily the same as it was prior to them getting the hearing aid. So there is some period of adaptation there. Another issue with a lot of hearing aids, they can be very expensive. Not very many insurance companies will cover them. Medicare does not cover hearing aids. So this is something that a lot of patients need to be aware of. There are prescription hearing aids where an audiologist will be responsible in terms of the management of the hearing aid, in terms of the programming. And then there are over-the-counter hearing aids. Over-the-counter hearing aids were recently approved by the FDA. They provide some benefit. However, they're not able to be programmed and tuned to your specific type and severity of hearing loss.
I understand also that Apple EarPods are now being utilized as a type of hearing aid.
This is all very exciting. The over-the-counter hearing aid approval and now in the last few months, the Apple AirPods and now being able to actually do a hearing test on your phone is, I think, only going to improve the overall health of the population in terms of hearing awareness. I think these are all very excellent developments, and I've spoken with my audiologists and audiologists across the country, and they say that it has really improved patients' appreciation of the importance of hearing well.
Let's go on now to a very exciting development in your field, which is cochlear implants. When were they first developed?
Yeah, so the first cochlear implant was developed in about the 1970s. They have been around in terms of FDA approval in the 1980s, but only recently has the technology within the last 15, 20 years been good enough where people feel like the original what we call indications or whether or not a person would qualify for a cochlear implant has become more widely available. It's a very remarkable achievement of the intersection between medicine and technology. It's the only surgery that can be done to restore a lost sense. Looking at the outcomes for children, if a child is born deaf and they receive a cochlear implant before the age of 5, they will have the same speech and intelligence scores as a patient without, as opposed to a patient that was born hearing. And many adult patients find that the use of a cochlear implant allows them to regain much joy in conversations and appreciating music, and can really change and improve these patients' quality of lives.
If somebody has had near complete or complete hearing loss, what happens when you do the surgery? Do they hear immediately at that point?
That's a great question. So the sound that my patients will describe at the first, what we call activation visit. So when we do the operation, the patient will wait about 2 to 3 weeks before the cochlear implant is actually turned on. they will be able to appreciate the different tones. However, it will sound a little bit more synthetic, or what they describe more tinny. And that's because we are really using the part of the cochlea that works well with high frequencies. The low frequencies are not as easily accessed by the cochlear implant electrode. So those frequencies tend to be less represented. But yes, patients will be able to hear right away once their device is activated. What it sounds like to them is the process and really the hard work of audiologists and oral rehabilitation therapists.
So based on what you're saying, you may turn somebody who has complete hearing loss or near complete hearing loss, and after a period of adjustment and rehabilitation, they could hear music.
That's correct. It will sound different to them, but it is something that they will get used to. And it is, I've never had an activation that has been remarkable. I've never seen somebody so happy after every activation I do. It's incredible.
It must be very moving.
It's moving. Every single one is moving. And it's a true feat of modern medicine that we're able to do this. And what's so exciting is that it will only continue to get better.
That's just absolutely remarkable. How long does a procedure take?
Procedure itself is about an hour and a half. And then the procedure is usually done at a surgery center, depending on the patient's health. Usually can go home within an hour after the operation. The pain is very minimal. Most of my patients take Tylenol or Motrin for pain, hardly use any stronger painkillers. They come back to see me at about a week to make sure that everything is going well. And then I have them see our audiology team within about 2 to 3 weeks. And that's when they have the implant turned on.
Wow. Is this covered by insurance? Because you said hearing aids are not. So what about this?
Yes. So the wonderful thing here is that with proper candidacy, the patient will have it covered by insurance. And what's exciting is commercial insurances now will cover what we call a cochlear implant for single-sided deafness. So if somebody were to lose their hearing in one ear from an accident, which happens not infrequently, or they lose their hearing in something called idiopathic sudden sensorineural hearing loss, where the ear has a sudden drop in hearing, it's very hard to recover that with medication. They can restore the hearing now in one ear, which will help with sound localization, which is very important for safety, knowing which direction a car is coming from, and being able to hear in a noisy environment.
If somebody does not have insurance, what is the average cost around the country for a cochlear implant?
So the device itself is approximately $25,000. But usually the fees are higher than that because you have what we call facility fees, the fees to use the surgery center. It is, unfortunately, I would say, prohibitively expensive for somebody to get this done without insurance, though.
So it can cost, I guess, $30,000-$40,000. In that range?
Around that range, yes. Yeah, but fortunately, Medicare, Medicaid are covering this operation.
Sure. Now we're putting up another illustration of the implant that shows what it looks like externally. Can you talk our viewers what exactly they're seeing on the screen?
So the cochlear implant is actually two components. There's an external component, and that's the microphone that sits on the skull, on the scalp, right above the ear. That device has two main components. It has a microphone to detect the direction of where the sound is coming from, and then it has basically a computer that processes that sound, and then through a magnetic connection that sends that sound to the internal component, or what we call the receiver stimulator, that then converts that sound signal into an electrical impulse through an electrode that I place into the cochlea. And most of the technological advancements have been actually in the external processor. So a common question I get from patients is, well, what if there's an update? Well, the vast majority of updates are going to be with the processing of the sound. And the receiver stimulator really there have been important advances. It's gotten thinner. The material to make the electrode has gotten softer, so it doesn't damage as much of the cochlea. But the workhorse is really going to be the external component.
We only have 1 minute left. I'm sure our viewers are wondering, with these external components that you implant, how does it work with showering, bathing, and swimming?
Yeah, very good. Yeah, so the external component can be removed at night showering, and there are some caps that you can place over it for swimming. But the main recommendation is to avoid water exposure. But there are no connections with the internal component other than with the magnet. So the amount of potential for skin irritation is very low, as it's just a magnet sitting on top of the scalp.
If our viewers have any questions, how can they reach you?
Sure. Well, I have a website. It's drahmedent.com. We can go ahead and receive your appointment request on there. There's lots of information about cochlear implants on this website. But also feel free to give my office a call. We have offices in Gaithersburg and Silver Spring, and really looking forward to seeing you all.
Dr. Ahmed, thank you for a superb interview.
Thank you for having me.
My thanks to Dr. Mostafa Ahmed for a terrific, informative interview. My thanks to my team at the station for putting this program together. And finally, my thanks to you, the viewer, for joining us this evening. Tell us how we're doing. If you want to reach me, you can reach me at the website listed below on the screen. As for our show, next time, we'll be reviewing an important topic rarely covered on television: pelvic prolapse and the urogynecologic surgical approaches to provide symptomatic relief. It's going to be an important, informative show. See you then next time for another edition of Housecall. Good evening.